Okay.
She is a 38-year-old lady with history of occasional right hypochondrial pain, vomiting and fever, history of weight loss. Her lipase was on the higher side at the time of investigation, otherwise labs were within normal limits. Her previous CT showed a 12 into 16 mm and 16 into 16 mm lobulated central enhancing lesion in the pre-cable and peripancreatic region. So previously EUS FNB was done and that showed hypoechoic mass and biopsy was taken. That was suspicious of small round blue cell tumor and the differentials included lymphoproliferative tumor or neuroendocrine tumor. But the review histopathology did not show any malignant cell. So we repeated the CT of this patient and the size of the lesion increased from 16 to almost 27 mm. And that was in the peripancreatic and the pre-cable region. So this was most likely a nodal mass. Her CT chest was normal and there were no mediastinal lymph nodes.
Mind you that round blue cell tumors are extremely rare in this region.
Yes, only 10 cases have been reported till now.
11th has been reported by Vinay.
So we are going to
12th is
repeat.
going to be reported by Shafqat Rasool.
We are going to repeat EUS and do the FNB. Over to you, Dr. Shafqat and Dr. Nadeem.
So before you do that, Dr. Faria Shams there.
Dr. Faria is here.
Have you reviewed the images with the audience, the CT scan?
Yes, I think that would be a good idea to get the images reviewed.
Because this is a very interesting case. We've got some very nice images to show you.
I think Faria is there to review the EUS images first. But then we can request her to come back and to review the CT images first and then go back.
It's okay, we can do maybe later on. That should be fine. But I thought it was really useful for us to have a look. So let's start off. Shafqat will start off from the station.
Nadeem, can you please adjust your mic? Although you're audible, but quality voice is not good. Thank you.
Can you hear me?
I can hear you. We can hear you very well, but not Nadeem.
Okay, let's start with some diagnostic details first. When you go to the cardia, firstly, when the scope is across into the stomach, you should do some suction because air is the enemy of EUS, and then you should do a tip up maneuver. And the first thing you will see is the left of the liver. And left of the liver, when the scope is all the way into the anti-clockwise position, you will see a vessel traversing the left of the liver. This is left hepatic vein, and the segment of liver above left hepatic vein is segment 2, and the one below is segment 3. And then you move the scope clockwise, and on the way you will see this fish-eye appearance. This is umbilical portion of portal vein. And you can see a cord-like structure going towards left. This is ligament artery, and the part of liver above this cord-like structure is segment 3, and below is segment 4B. Yes. Then you will withdraw your scope, and you will go to the other cord that is going towards the right. This is ligament of minimum. This connects umbilical part of left portal vein with IVC, and you can see a vein below this is pretty hepatic. So if you can freeze for me,
Jim is to show a kind of linear equilibrium structure for it.
So you can see a cord-like structure here. So this is ligamentum minimum, and the segment above this is segment 1, below is segment 4A, and the one below is segment 8. And then you go further clockwise, and you will see you will see the right hepatic vein. Can you repeat, please? This one. This one. This is right hepatic vein, and above is intrahepatic IVC. The segment of liver above is segment 1. This is segment 8, and 8, and this is segment 10.
Yep.
So we will moving further clockwise.
So before you do that, I think just a quick reminder, yesterday when we were doing a case when we had a stent in situ, so there are additional advantages of examining liver. When you are actually looking at the tip of the left segment portion of the liver, you want to see if there's any perihepatic ascites. Because that's quite useful, especially when it comes to staging. There are other reasons why people would have ascites, but that is something which adds to the management, overall management of the patient. So, secondly, you can obviously look for any focal liver lesions. And thirdly, what you want to do is you want to make sure that any air and you want to make sure that the stent quality is the intrahepatic pneumonia that would be consistent with the patency of the stent. So, first, around the perihepatic flow, looking for perihepatic ascites and lesions, and also any intrahepatic pneumonia, which could indicate any previous pulmonary intervention.
Dr. Just a mic a bit.
So if you move further clockwise from here to the 90 angle of around 90, you will find aorta. Can you see the aorta?
Yeah, partially. We need to just scope a little bit. Yeah. Okay, now we can see.
So if we continue following the aorta by pushing the scope, and some anti-clockwise to the left. Yeah.
Yeah.
Yeah. You can see two vessels there. The one close to the transducer is splenic artery, and the one below is splenic vein, and the part of the pancreas that you can see on the left side is body of pancreas, and you can see a small structure there. This is pancreatic duct. You can apply the Doppler. Yes, you can see there's no flow. From here, if we go anti-clockwise, we will be going toward the neck of the pancreas, and you will be seeing splenic vein forming confluence with peripancreatic vein to form the portal vein. You can see splenic vein, peripancreatic vein, and portal vein.
And we can see another vein joining. Which is that?
So this is splenic vein.
This is longitudinal vein. What's happening here?
Inferior mesenteric.
No. Come once again.
Okay. You can see the pancreatic duct dipping down across the neck to the head. In some thin limb patients, you can see a part of head from this side. If you
Okay, there's a nice presentation of the pancreatic duct just falling down there. There you go.
So the PD is dipping down in the neck of the gland, which is so the part of the pancreas which is in front of the portal vein confluence is actually the neck of the pancreas, and that's where you see the pancreatic duct. Ms. Samad, I'm sorry, you asked about that vein earlier. We thought that was inferior mesenteric vein. Did you agree or not?
No, I don't, because it's coming from the left side. It's the coronary vein.
Oh, fantastic! Can you go back? This.
that the left not really.
This one.
Yeah.
Oh, fantastic. So splenic, portal, superior mesenteric, obviously, so yeah, you're absolutely right. So inferior mesenteric, if
Yeah.
when you see it, it should come from that angle. Absolutely, yeah, no, that's right. Thank you. Okay. Okay, so Shafqat is trying to see if we can visualize the head of the gland and see if we can see the CBD from here, because I think it's important to visualize the CBD from 3 different places. If you can see it from the stomach, it's always best because there's no compression of the probe onto the CBD, so you can actually able to adequately measure the caliber of it. But it's not always possible, but if you can, that is always helpful. Okay, so yeah,
So,
go on.
so you can actually see that. Yeah, I think this patient has probably the thin patient. You can see the anatomy very well. So maybe worthwhile just mentioning that you can actually see the uncinate part of the uncinate also from the transgastric route. If you can just find out the superior mesentery coming out of the aorta, then in between the aorta and the superior mesentery, you can see the uncinate prostate.
And on the other side of the screen, you can see the mass.
Yeah.
This one.
Right.
So this is the mass. But we'll be seeing this in a better position when we will be examining from the duodenum.
Right.
Then we will be moving toward the tail of the pancreas. For that, we need to move the scope to clockwise, keeping pancreatic duct or splenic vessels in view.
Yeah, I think it's probably
Yes. No, I'm still with the stomach. So I'm moving toward the clockwise position toward the tail of the pancreas. You can see kidney.
yeah.
No, this we have reached till the tail of pancreas that is dipping between the spleen and the kidney. So pancreas looks normal. Pancreatic duct as well as the parenchyma looks normal. There is nothing in pancreas, and the mass we saw appears to be the peripancreatic region. So we will be shifting to the duodenum. And duodenum looks some deformed, there is some deformation of duodenum, and we were unable to pass across into the D2.
So there seems to be a stricture at D1, D2 level.
Stricture rather than narrow.
We're able to get into the bulb, duodenal bulb. So I think you can probably see two-tone differentiation here.
Yeah.
So dorsal went to pancreas.
Yeah, so you do see those two-tone differentiation of the pancreas. And I think pancreas appears normal, so the acrogenicity and the liquidity is normal throughout. But then you start to see this area.
Yeah, there's the mass. Yeah.
So this is the mass that Myers.
So we measured it earlier, about I think 17 into. So it's just adjacent to the portal vein. Yeah, so it's about. Now that's what you better measure, isn't it? So we try to instill some water into the duodenum, and we don't think it's originating from the duodenal wall. It seems to be extramural. There's a fat plane between the actual this lesion and the pancreas. The pancreas is on this side, and that's the area of abnormality. It doesn't really look like a node. It is well defined. It is hypoechoic. The reason I say it's not a node is because we can't really appreciate hilum. Obviously, it's not possible in every case, especially with some malignancy. But I think you can really make out nodes separately if it was. But we don't believe it is. We'll hopefully have a further look at it and see if we can.
Yeah, it's quite heterogeneous also. There are some hyperechoic spots in that.
Absolutely.
Is it because of the previous biopsy?
Can be.
Possibly, yes. So the origin is not from the pancreas. It doesn't look like it's originating from the duodenal wall, although we couldn't really get a lot of fluid into it. It doesn't look like a node. It is hypoechoic, so obviously it was sampled and I think there was suspicion about this blue cell tumor, which I think as Professor Riaz said and Shafqat said earlier, very handful of cases reported, so this could be another one from this center. Any comments from audience and the panel at this stage?
Dr. Nadeem, can you please put the doctor interrogation first?
Yes, so I think that's another very important point. What we want to do is, we want to see the internal vascularity of the structure, and so it doesn't seem to have increased internal vascularity, because I think one of the other points that you will want to think of, could this be a cyst? But I think, again, if it was cyst, then I think we would have probably seen a bit more.
And can you put the power flow to just detect the slow velocity vessels here?
You want to see the power flow?
Yeah. And do we have elastography as well?
I think we do.
Yes,
we can have a look at it later on.
Yeah, so that would help because that would help actually to target the biopsy, because previous biopsy, which they're saying they're inadequate tissue and all this, elastography may help you where to go.
That's enough. So that's the elasto. I mean, we can do an elastohistogram. I'm not sure if you can do it here.
You can actually, you can, yeah, there you go.
But it's not predominantly blue.
Yeah, but it's a mixed, right? So that's what I'm saying.
I mean, it's still a mixed picture.
Yeah. My worry is that you put in and it might not very well. I mean, not
So should we proceed with the biopsy?
Yeah, you should.
Okay.
My suggestion also would be that if you can put a 19 gauge also, to do both of them.
Okay. So do we have a 19G? Or a pro? Yeah, but 20.
Dr. Nadeem,
G.
can you please explain how this, because this is very ill-defined, I would say, not very well-defined, although I can see the margins, it is well marginated though. How this can be differentiated from solid-looking mass arising from the duodenal wall on the EUS findings, because I'm trying very hard to differentiate these two on this very image.
Sorry, I didn't get your question. Is your question, where is the origin of this massive?
My question is how we can differentiate this, basically to discuss the differentials, how can we deny that it's not a nodal mass and this is something which is arising from the duodenal wall? Are we able to see the duodenal lumen clearly and that's not infiltrating the duodenal wall?
Yeah, so I think what we did earlier, we tried to fill the duodenal lumen with a lot of water, and we tried doing it again. And we did not feel that it was originating, so we tried to fill the duodenal lumen. I think there's a bit of a stricture, so we can't really get much fluid attempts to spill back into the stomach.
But I can appreciate. Hello. So what I can appreciate is the duodenal luminal air that I can see, but I cannot see this serosal wall clearly between this heterogeneous looking mass from the separate from the duodenal wall. So my concern is whether this is something arising from the duodenal wall itself, or is it something which is infiltrating into the duodenal wall, or neither of the two.
So you should be seeing, hopefully you'll start seeing some filling of the water into the second part of the duodenal lumen.
Initially we thought that it's rising from the duodenal wall, and we filled some water, and it doesn't look like it's coming from the wall.
No, absolutely. So we couldn't convince ourselves.
Yeah, you can see actually it's sliding along with it.
Exactly.
So the duodenal wall is separate from it, it's sliding along the duodenum encapsulated. And so you don't have a balloon over that, so maybe sometimes a balloon would help all of the support. But anyways, I think it looks separate.
So we felt, that's one image I'll see if I can show you. So we felt this is where it is. So I think it's definitely separate from the duodenal wall there. So that's I agree. It's not straightforward, and that possibility remains.
Or then, yeah, so what we adjust or something, what do you think?
In differential, symptomatologists have given a differential of net 2.
Yeah.
So, but it's not that vascular.
Did you do an immunochemistry? Chrome granule and things like that?
So do you think can radial EUS be helpful in this case particularly because we are not able to define the tumor wall very clearly? So if we are not sure whether the mass is arising from the tumor wall or is it extrinsic, so will radial EUS help here?
Yes, I think certainly. The only issue we had is that we struggled to intubate even the D1 earlier, and there's definitely stricture at the D1, D2 level. So that may be slightly tricky, but I think that's a very valid suggestion that this could all well be originating from the renal wall, and I think radial scan should help in that setting.
Needle was not coming with these, so I'm adjusting the needle.
90.
Dr. Anjit, you were discussing about the last
You can see needle coming out. You can apply it from Doppler.
we have a little bit of idea of the Doppler, but if you can elaborate the elastography, what's the blue and the green, and how do you define it?
My point was that if you have very so my point was that it seems to be anechoic area that's on this thing in the previous biopsy that we did other doctor.
Firstly, we need to sharpen the needle.
So you want to target the areas which are
You can see the needle is inside the lesion.
and hard. So maybe doing elastography and giving a map, so where to check. So
You can go for slope method.
Blue is bad. Green is good. So the green is usually the norm, which is elastic. And as the elasticity decreases, in which as you can see, there's a map. So that's the simplest one. Stiffer. You want to go to the stiffer, especially as you can see there also.
You can see the move.
Yeah, so we need to fan it and maybe target the
Yes, we can move the needle inside the lesion with your elevator with a big wheel. Move in the different directions. Do the fanning.
Yeah. Shafqat, your boss is not happy. We're only drilling in one place.
Okay.
So I think the challenge here for Shafqat is that he's
Position is.
yeah, absolutely. So
And at the same time,
You
you
get a
can
lot of
do it
blood.
at one place only. Why not to use the suction then?
Yeah.
Now moving in the different directions.
Right.
Fine, now I can see that you're moving in different directions.
So the guy who moves 1 millimeter at a time.
Okay, Shafqat, while you're doing the biopsy, can we switch to the new room? We're going for Dr. Rasool.
Yes, you can.
स्विच करें भी डॉक्टर ग्यास स्टेशन 1 पे
Are you back with us in the room there?
Give us a moment, please.
Lovely. So we have changed
Yes,
to
hold,
the US scope now.
just hold on for a moment. Just
Okay.
hold on for a moment. Let us split. One more minute. Okay.
We are back with you.
No, screen as well.
Screen भी लेके आओ पैसा
So are we successful?
Rendezvous. नहीं अभी भी उसके साथ हैं हम शफकत के साथ
उसको बुला